shifted already. In the initial women that we saw at NIMHANS, we generally saw a later onset of use, particularly of alcohol, less alcohol consumption, likely to be married to an alcoholic partner, divorced or separated. They sought treatment at the same age as men with the same severity of dependence. I talked to you about telescoping. We used to get women predominantly with neuropsychiatric disturbances. So they would not come for other disturbances because they would continue to maintain their role as a housewife, as a family member till they develop neuropsychiatric symptomatology. And of course, we know that there can be more physical adverse effects in terms of what happens in terms of the blood alcohol concentration and so on. But this is a traditional pattern. It has already changed. And I think therefore we need more studies now to look at the change patterns amongst women. So this was a study that we carried out on substance use women in high risk with the UNODC, which was again, as I said, in the late 2000s. And there, dual diagnosis was very frequent, increased risk for suicide. So both in women who were using drugs and women partners of men who were using substances, there's a high likelihood of suicidal ideations as well as completed suicide. And of course, women generally tend to enter treatment mainly because of health problems or family problems. It's rare that a woman is brought for addiction treatment mainly because she's addicted. Again, I'm talking about this pattern about 10 years ago. Nowadays, we have women who come in primarily for their addiction. So I think that difference needs to be understood. So just to summarize the gender dimensions, we're looking at predisposition, modeling as from a biological perspective, modeling as a social perspective, peer influences, ongoing stresses, stigma and fear of getting into treatment and acknowledging substances, and lack of knowledge of harm and ignorance about treatment facilities, lack of gender sensitive services. I don't know if Subodh you'll cover some of the barriers to substance use treatment. You will do that. So I'm not going to talk about the specific barriers, but enough to say that role transition and lifestyle as continuing precipitating events, social disadvantages, location. So now we've started to see two kinds. One is the poor, underprivileged kind of person who gets into substance use, the very affluent, well-educated, younger persons who come into substance use. We're starting to see both these patterns coming to us for treatment. So, just to understand that all of these are not operating in isolation, to this morning's discussion about availability, accessibility, of drug use, accessibility to drugs, and lack of alternatives, combined with influence of peers, media, as well as poor life skills, temperament and coping, which is always in the background, to a genetic vulnerability, as well as lack of family support. All of them are vicious cycles in which the whole system of women use drugs. So this is a study which talked about the impact of childhood adversity from a gender perspective, and they looked at the NESARC data in the US, a very large data set of more than 19,000 women and more than 13,000 men. And they looked at the risk related to exposure from childhood adversity. So overall, while women seemed to have a lower risk than men, moderation effects showed that with more number of childhood adverse experience, the gender gap in terms of the predicted probability for a disorder reduced in relation to alcohol. And it was the same with relation to other substances. But the moment you looked at polysubstances, the women overtook the men as far as relationship to gender adversity is concerned. So, in terms of the impact from substance use, I'm supposed to cover the risks. So I talked about the risks for substance use. Now I'll just mention the risks from substance use, and maybe Subodh will allude to that a little bit more. This is just a kind of overall presentation that, remember, when usually there is drugs, there is invariably alcohol and tobacco. So it's a triple whammy from all these disorders. It's a triple whammy from the drug use. It's a triple stigmatization from the fact, generally, especially when in societies where women, there is an issue of inequality starting off. There is a discrimination against drug use. So women generally tend to be discriminated both as also as bad. There is another kind of connotation in society which considers these women as bad, and that increases the stigma again of talking about drug use and coming to treatment. So there are individual consequences. Of course, there are family consequences. We're increasingly seeing workplace consequences as well as community consequences. In fact, I was very tempted to put a few of the pictures of women getting caught in drunk driving, and you'll see that they become headlines. Even if there is no major adverse outcome, the fact that a woman is picked up, particularly in the local television channels, it's horribly sensationalized when women. In Mangalore, there was a thing about women being at a party for, which was some kind of a, party with psychoactive substances. And it was terrible that the gender angle kind of overrode all of the other angles to that. And therefore, I think there is a huge impact, not just on the individual, but on society as well. And the spectrum of problems may be from intoxication, from physical damage, social consequences, the triple stigmatization of being a woman, of using substances, as well as the consequences of it. And of course, the reproductive consequences, which I told you are not just to the newborn, but also in subsequent generations. So in the thing that done in the study undertaken by our clinical psychologist, we found physical problems in a majority of the women, interpersonal conflicts, comorbid axis 1 disorders in nearly 2/3 of patients. And that is not something that you find across, it is more specific to this gender. Access to diagnosis are not very high. And the relapse rate is extremely high. Tragically, I remember an early study I did of 10 women, because that's all we could get. At the end of 1 year, there was no information on none of those 10 women came for follow-up. So it's very important to have a much more proactive follow-up for women, because they tend to drop out of treatment. Now, I remember I told you earlier about the prevalence of HIV among persons with injecting drug use. And the important thing to understand is that globally, about 1 in 5 persons who inject drugs is a woman. So we're talking about 20% of drug users being a woman. And you'll find that in terms of the prevalence of HIV among persons with injecting drug use, to look at the latest data, you'll find that there are higher prevalences of more among women than in men in terms of HIV data. And so that's again something very, very important to remember. Apart from physical health consequences, there is a close association between drug use and violence, drugs and sex, especially income for sex, which is very different from just commercial sex work, where also substances are used very often. Drugs and mental health consequences, effect on the children. In many families where both women and men are using drugs. So in families where men are using drugs, the woman partner is able to manage. But when both of them are using drugs, you'll find that parenting becomes a huge problem. And I'm sure that will be discussed in the next session. And then grandparents, if they are available, become the parents, proxy parents for these children. And when there is lack of social support, the entire thing becomes very complex. These are some of the early studies that we did in as far as women and substance use were concerned, but the profile has changed since, and we need an update on this particular issue. As far as alcohol is concerned, we do know that women tend to develop a higher concentration of blood alcohol. We know that alcohol, they get intoxicated at lower doses of consumption. We know that alcohol dehydrogenase is less effective in women than in men, so that women tend to absorb more alcohol as compared to men taking the same weight. We also know that the effects of alcohol in women will be longer lasting, and that the woman's ability to metabolize alcohol is further affected by the menstrual cycle, and therefore premenstrually intoxication may be higher. And combining alcohol with prescription drugs is another risk, and heavy drinking can be associated with stroke, osteoporosis, as well as risk to cancer. Pregnancy with alcohol, earlier there are several studies which, some initial studies said no effect. Then we talked about alcohol-related birth defects and alcohol-related neurodevelopmental disorders. Now we know that there is a fetal alcohol spectrum that can occur, and of course, the worst outcome can be neonatal mortality or intrauterine death from the use of substances. With tobacco and alcohol, there is a fair amount of literature which associates it with low birth weight, fetal growth retardation, spontaneous abortion, and sudden infant death syndrome. And these complications are correlated with elevated CO levels associated with both maternal as well as fetal hypoxia. And children of heavy smokers may indeed have a neonatal withdrawal syndrome, just like the parents can have. Pregnancy and alcohol, I have not come across too many studies. This is one study which my student Raghavendra did more than 10 years ago, and which suggests that there was a reduced palpebral fissure and intercanthal distance ratio, a very smooth philtrum, and a thin upper lip in children who were exposed to substance use. Of course, it's very important to follow up these children, particularly for intellectual as well as behavioral abnormalities. That's because there can be a lot of neurocognitive deficits, from intellectual dysfunction to learning difficulties, attentional problems, visuospatial difficulties, a whole lot of subtle neuropsychological functioning, as also behavioral problems in terms of ADHD, conduct disorder, risk to substance use, and poor socialization and communication skills. With benzos, we do know that there is a risk of malformation, particularly in early exposure. And if drugs are administered at or near term, there can be fetal dependence and eventually fetal withdrawal symptoms. As far as opioids are concerned, again, low birth weight, antepartum hemorrhage, and neonatal mortality is known. And women also can have, significantly poor attendance at antenatal or, postnatal health services, and a greater risk for antepartum hemorrhage, low birth weight, as well as neonatal mortality. So in summary, what I've told you is that substance use, both among girls and women, is a growing problem. We talked of cohort effects as far as male drug users were concerned. We are seeing an exaggerated cohort effect, which means young girls are certainly becoming, more vulnerable, or high prevalence is increasing among younger people, particularly girls. Epidemiological approaches have started to include women in the studies, but we need to understand gender dimensions, particularly from the viewpoint of vulnerabilities